Okay. So, our first speaker tonight is Dr. Ed Hall. He's a general and thoracic surgeon here at Archbold. He earned a doctorate of medicine and completed a residency in general surgery at the Medical College of Georgia in Augusta. He has practiced general and thoracic surgery at South Georgia Surgical Associates in Thomasville for 32 years. Dr. Cianna Pender earned a Bachelor of Science degree in biology from Rhodes College in Memphis, Tennessee, and a doctorate of medicine from the Florida State University College of Medicine. She completed a residency in general surgery at Louisiana State University in New Orleans. She specializes in general surgery at South Georgia Surgical Associates in Thomasville. Please help me welcome Drs. Hall and Pender.
So there's one thing that we notice over and over and over is that there's kind of a poor awareness about lung cancer. We have all these things for, Breast Cancer Awareness Month, and those are all wonderful. But what we want to show you tonight is that lung cancer is a very big threat to your health or your friend's health, and that there are ways to head it off at the pass, and that we have some unique techniques to do that. Dr. Pender is going to explain to you a lot about the, where's the clicker? The click, just click there. So she's going to explain to you a lot about the sort of the statistics about it and about what we know about screening now and what's the appropriate thing to do for screening if you're at high risk, and some causes and what you can do to prevent it. And then I'm going to talk to you a little bit about the surgical aspects and what we do here that Dr. Pender and I do that are unique to Archbold that we're very, very proud of. And so I'll turn it over to Dr. Pender, my capable,
All right,
younger
won't be long.
partner.
So what we're just going to talk about first is a little bit about what lung cancer is, where it comes from, what the risk factors are, how you might be able to identify it in yourself or your loved ones or others, and then we'll move on to what we do about it once we've found it, okay? So how common is it? Like Dr. Hall said, you hear so much about breast cancer, colon cancer, prostate cancer, and every lung cancer has its own awareness month, and November is Lung Cancer Awareness Month. Lung cancer is the second most common cancer in men and women. So breast cancer is most common in women, then lung cancer. In men, it's prostate cancer, then lung cancer. And lung cancer accounts for about a quarter of all cancer diagnoses in the United States every year. It occurs mainly in older people, and when I say older, that is ticking closer to me personally every day. Ridiculously, it seems, even 55 is considered geriatric these days because of all the people that are on blood thinners. So older doesn't necessarily mean old.
Thank you.
Yes. It comes with many more caveats as the days go by. And as probably most people know, smoking is your big risk factor for lung cancer. Though it's not the most common cancer in men or women, it is the cancer that accounts for the most death in both men and women. Which it just says a whole lot. That this is a little pie chart just to sort of illustrate, but of all the cancers we know of, all of them, 41 other kinds of cancer, lung cancer accounts for a quarter of the deaths, even though it does not account for a quarter of all cancer patients. So, what is lung cancer? Lung cancer is a cancer that starts in the lungs, obviously. They develop small and grow slowly over the years, though some can grow kind of quickly. Just a little bit of brief anatomy. You've got your main windpipe that comes down your neck here, and your trachea that comes down the middle separates into two main airways that separate out into your right and left lungs. And your lungs are referred to in pieces called lobes. On the right, you've got 3 lobes, and on the left, you got 2 lobes. And this is all separate from your abdominal cavity by a thin layer of muscle. And your lungs really, they look like those dried sea sponges. If you can imagine a sink sponge that's very pliable and squishy with a lot of air holes in it, and when you squeeze it down, the actual volume of tissue is not that much. That's really what your lung is a lot like. And so, basic mechanism of breathing is you breathe air in, it fills your lungs, it fills this tissue and the little sacs at the very end of the tissue pathway called alveoli, and then you breathe out, your chest wall squeezes all the air out, that muscle that separates it from your abdominal wall helps you, and that's how you get air out of your lungs. And most lung cancers start way down here on the microscopic level in those little alveoli and the cells that line them. There are two main types of lung cancer. One is called small cell lung cancer and one is called non-small cell lung cancer. And most lung cancers that we identify are non-small cell. And that encompasses a whole bunch of other kind of subspecial pathologies that I'm not going to cover tonight because there's a bunch of them. So, what causes lung cancer? That's what we all want to know, right? Because if we know what causes it, in theory we can prevent it. Well, you would think we would be smarter about this, but we're not. Most of the lung cancer is linked to smoking. Okay, something as simple and as common as smoking causes 80% of all lung cancers, which causes 25% of all cancer deaths. You would think we would just be smart enough to not smoke, but it's not that simple. The other 20% are usually related to other exposures, secondhand smoke. We'll go through a few of the other environmental exposures here briefly. And a very, very, very few number of lung cancers are actually hereditary. It's not linked like breast cancer is or prostate cancer is. There are only very few lung cancers that are genetically passed on through the generations. So, tobacco smoke is the leading risk factor. That includes cigars, that includes pipe smoking. Any sort of inhaled tobacco product puts you at risk. That also includes hookah smoking. The data is still out on the little vape cigarettes that are very popular these days, but I wouldn't put my money on them. And then secondhand smoke. Sitting next to somebody who smokes for 40 years, for 50 years, also significantly increases your risk of lung cancer. Another leading known cause of lung cancer that we've actually done a very, very good job in eliminating to the general public is radon. Radon used to be much, much more common in the United States. We figured out it caused lung cancer and the EPA put out some bans against it. And now I would bet you every smoke detector in every one of your homes both detects radon and carbon dioxide. I'm sorry, carbon monoxide, not carbon dioxide. And so that is something that we actually did a very good job identifying as a risk factor and eliminating it from the general public's risk. Other more rare causes of lung cancer are asbestos. I bet everyone's seen the mesothelioma commercials on television. Another rare kind of lung and chest cancer directly related to asbestos, arsenic, and then a bunch of other more rare environmental type exposures. Other risk factors, radiation therapy to the chest. Sometimes people have need for radiation to the chest for other causes, which can put you at an increased risk. A personal history of lung cancer is actually considered a risk factor for developing another lung cancer. We talked about lung cancers and family members can rarely be related to a personal risk, and then just generalized air pollution. see on the television folks in other countries wearing masks just to walk down the street, just to go to work from the air pollution, from smog. Also a risk factor for lung cancer. That's why we live in Thomasville, right? So just a little public service announcement. The best way to reduce your risk for developing lung cancer is to not smoke. If you're a smoker, you should stop smoking. There are so many resources available to help. It is hard. Everybody recognizes that it's very difficult to stop, but there are a lot of people and a lot of organizations that want to help you do it. So we've got good information on that, and we can put you in touch with people that can help. So let's just use breast cancer as an example because it's more common. How do we screen people for breast cancer? Mammograms, right? Every woman in this room knows what a mammogram is, right? Because it's just been driven home to us over the years. This is how we screen for breast cancer. That's where we're trying to get with lung cancer screenings, okay? For years, our only tool has been that chest x-ray, and it's pretty good. It's inexpensive, it's a low dose of radiation, and it's reasonable for detecting lung cancers, but it's not great, is what we've come to find out. And over the years, as our technology's improved, we've figured out CT scans are actually much more sensitive for detecting lung cancers at an earlier stage, which gives us a chance to cure them. And so, sort of a more recent development in the medical field is the use of these low-dose CT scans to screen people for lung cancer. And you can think of it like a mammogram for your lungs. Okay? This is just a little pictographic representation. If you did a chest x-ray on 100 people with risk, or sorry, rather this is a graph, 100 people that we know have cancer. If you do an x-ray on them, only one of them is going to show up positive on the x-ray definitively. And then another 16 are going to have maybe studies. You can see the low-dose CT scan screen doubles your chance of catching it early. And there's been a lot of good data published over the last 10 years that supports the use of low-dose CT screening as the preferred tool for lung cancer screening. There was a 20% mortality reduction in this study, which is just incredible. Like we talked at the beginning about, the survival rates for lung cancer are appalling when you compare them to some of the other common cancers. If you're diagnosed with prostate cancer, your chance of being alive in 5 years is almost 99%. And if you're diagnosed with breast cancer, it's almost 90%. If you're diagnosed with lung cancer, your chance of being alive in 5 years is 17%. That's not very good. And the question is why? Why is the survival so much better for these other cancers? Well, it's because we screen better for them and we catch them earlier. The real problem with lung cancer, and you'll notice I skipped over what are the symptoms of lung cancer. It's because the answer is often there are none. Very often, until lung cancer gets late stage, you will not have any symptoms from it, unless it's doing something particular kind of in the middle or in a large airway. You may have no symptoms, and that's why the survival rates are lower, because we don't catch it as early as we catch these other cancers. And it all has to do with the screening. And so, the screening recommendations have changed over the last 5 years. It's gone from chest x-ray to, if you are 55 to 80 and you have 30 pack years of smoking history, which means you smoke 1 pack a day for 30 years, or you smoke 2 packs a day for 15 years, or you smoke 4 packs a day for 7 years. All that adds up to what we consider a pack year of smoking. So people 55 to 80 with 30 pack years history who are actively smoking or who have quit in the last 15 years should get a low-dose CT scan to screen them for lung cancer. And this has been a major paradigm shift in medicine, one that we're still really trying to drive home with our primary care providers. But as you can see, very rarely in medicine do multiple societies agree on recommendations. Just about everybody agrees that this should be the screening measure of choice for people that are high risk. So, with all of this data being presented, hopefully we convince people of the importance of screening, importance for catching the disease earlier and improving our survival rates from lung cancer. And you've decided you want a screening CT scan, you're in luck. We screen people, and we are happy to do so. We actually have a special grant here that allows people to be screened free of cost for high-risk patients. In addition, all of the insurance providers, commercial, Medicare, Medicaid, pay for this screening test. That's how important it is, and how much all of the major organizations have decided that it's going to help prevent deaths from lung cancer. So this is the information on the screening CT scans done here at Archbold. Alternatively, you can ask your primary care provider. You can just tell them, I think I'm high risk, these are my factors, and I need a screening. And it should be something, hopefully, once we start getting the word out, that's as common as mammograms and as common as colonoscopies, to try to help prevent some of this morbidity and mortality from lung cancer. So Dr. Hall is going to take over now on the part of the presentation, talking about what happens once you've been screened and a nodule is found.
Yeah, when I started my training, there were no robots, there were no screening CTs, there were very rudimentary things that we would look back on now. I came here in 1986, and Dr. Charlie and Vance Watt still had rotary phones in their office. We didn't have cell phones, so we didn't have any of this. My new partner comes out of a training program where she learned to do robotics while she was training. I started learning about 7, 8 years ago. Took me about 6 months of just personal time training to do it, but we've been doing it here since then. And the hospital's been very supportive of that. We have now 2 robots, not 1, and we have a number of robotic surgeons. She and I are the only ones that do lungs, but several of our other partners and several the urologists, the gynecologists use it in their respective fields. So very proud of what we're doing here. I'm proud of the direction we're going, and I'm very proud of the fact that the hospital and the donors to the hospital have been so willing to put up the money to let us have this technology. So what I'm going to transition to now is sort of what happens when you get a diagnosis of a nodule, not necessarily cancer, how we work it up. Then what are the options of how we, particularly here, which a lot of the things we do here are not available at other even larger hospitals, and one of which is robotics, one of which is this new technology to biopsy things, and we're very proud of our screening program in that you really can get your first screening in particular free if need be. So after you have been screened and maybe picked up incidentally on something, you come in an automobile accident, get a CT scan, and we see it. But what we want to do is get the people who are at high risk to have these screening tests done on a yearly basis, and with that we can reduce that horrible mortality rate from lung cancer by 25%. And that's a huge number If you look at the things that we do for cancer, if we have a chemotherapy that reduces mortality by 5%, it gets approved. So we're looking at something that's 25%, which is a huge, huge reduction in mortality, and one of the cancers that is most likely to kill you. In fact, if you add up colon cancer, breast cancer, and prostate cancer all combined, it's all on the pie chart that she showed, fewer people die from all three of those combined than die from lung cancer in the United States every year. So, although it's not the most common cancer, it is the most common one to kill you. So we can impact that, and it has been shown in the statistics. So you may need a biopsy, you may need a PET scan, which is a certain way we do a CT with added nuclear medicine stuff to make tumors glow, so we know whether what you have is just a benign nodule or whether it might be cancer. All of those things are provided here, and some of them are provided that are not provided at any of our surrounding hospitals. So the various options we have when you do have a lung cancer or a nodule that we think is a lung cancer. Sometimes we can't biopsy them, but we either take out a wedge, the smallest operation we did one this afternoon, the segmental resection where we take out a segment of the lung, or a lobectomy, and then occasionally we have to take out the entire lung. And what most people don't realize is that most people can live without one lung. They can live on one lung, and we do various testing to be sure before we go into surgery as how much we can take out with the goal of curing the cancer. So what we have unique to Thomasville that we really don't have in the surrounding communities for treatment of lung cancer is we do robotic surgery here for lung cancer. We started in, like I said, 7 or 8 years ago. We've done over 500 lung cancers with the robot in this institution, or lung nodules, most of which were cancer. And that is a phenomenal thing to have available in a town of this size. I mean, we actually have 2 robots instead of 1. And we have the latest, greatest robot. And we're able to go in through very small incisions and take out lung cancers with less impact on the patient. Less, they recover more quickly. And I personally, having done it every way you can do it in my career, I feel like it is a safer way, a better way. I think we do a better job of getting the cancer out with the robot than we did with an open chest procedure. If you look at this, open thoracotomy, which is the conventional way that most surgeons, still 60% of surgeries in the United States are done with an open procedure where they cut you from the front to the back between the ribs, spread the ribs, which if you're my age or older, the ribs don't give very much, and so they break or they dislocate, and the postoperative pain is the worst incision that I inflict on anybody for any surgery that I do, would be an open thoracotomy, where we actually open the chest up, get our hands inside, requires spreading the ribs apart, and the ribs don't give. Thoracoscopic surgery, the middle part here, is what came along, and I started doing that in 1992, 93, and started progressively increasing the complexity of operations that I would do with what we call minimally invasive technique. And to show you a little difference about that, the degree of incision. A thoracotomy requires cutting between the ribs and spreading these ribs, which are very well attached in the front and the back. So we transition to this, what we call VATS, video-assisted thoracic surgery. It's the same technology we use to take out your gallbladder now, which is laparoscopic surgery. We use that same scope, very similar instruments and technique. So we were able to reduce this down to some punctures about the size of your finger and one incision which we call the utility incision, but it was still between ribs that had to be spread in order to get that exposure that you needed through that incision. So what we now do is robotic surgery, where all of those incisions between the ribs are small punctures and no incisions that require spreading the ribs. At the end of the case, when we have the tumor actually disconnected from the rest of the lung in whatever way we do it, lobectomy, even pneumonectomy, we come down to what are called the floating ribs, and this doesn't illustrate it as well as it could. The floating ribs don't attach in the front. They actually move very easily and don't dislocate and don't break the vast majority of the time. And we can spread those a little bit, but they spread on their own just because that's the kind of ribs they are. If you feel your rib cage, you can kind of push on those and they open up. And so we use that as our exit to make an incision however big the tumor is. The lung, remember, is like a sponge, like Dr. Pender told you, and it just collapses and becomes soft and will come through a very small incision. We can take an entire lung out, and if it's got a 2 centimeter tumor in it, we can take it out through about a 2.5 centimeter opening. We don't have to make a giant opening anymore to get the tumor out. And what that results in is far less chest wall pain, and because we're taking lung out and our biggest enemy is pneumonia and the patient's not taking a deep breath and not coughing well, that allows those patients to do that more comfortably. And we do a lot of other things now that we didn't used to do that allow us to decrease the pain, and our goal is to eliminate the pain if we can, because we know that our patients get better. When I first started training, we gave less pain medicine because we thought it sedated the patients too much and they wouldn't cough and wouldn't deep breathe. Well, we found out ultimately that that was the opposite of what's true. And so now we do this through these little punctures with the robot. Now the robot is just a tool. The robot does not do anything that we do not direct it to do. So what it involves is putting these little tubes into the chest between the ribs and hooking those tubes up to the robot, which is over the patient. Once that's done, I break scrub. I'm all scrubbed and sterile when I'm doing that. My assistant stays there, as do the other assistants in the operating room, and I go over in the corner and go to a console. That console, which you'll see with the visual like goggles there, allows me to put my head on those goggles, and all of a sudden I'm looking at a 3-dimensional view, whereas with video-assisted thoracic surgery, you're looking at a TV screen which is 2-dimensional. In 2 dimensions, you have no depth perception. So you're kind of trying to guess where you are, deep and all that. In 3D, you see it just as if you've been miniaturized and dropped in the chest. The other big deal about the robot is that the instruments themselves, although they go in straight, they then, as I sit down and put my head in that and put my hands in that, they become my hand. They become Dr. Pender's hands. They become all of our partners that do robotic surgery. They just do how we move our hands normally in surgery. So we're able to tie and sew and do all the things that we would normally do. It is the most incredible advance in my career as a surgeon, and as everybody's been very willing to tell you, it's a long career. So we're able to do, besides lung cancer, we do a lot of other things, esophageal resections and anti-reflux procedures. We have partners that are proficient and sort of do that as their niche. We can do all sorts of surgeries, including bariatric surgery, with this technology. It's incredible. I want to tell you about another technology that we have, because the robot changed my life as a surgeon. and I think impacted my patients more than any other development in my career, which spans some 120 years. But it's this Variance Navigation system. So now that we're doing screening, all of a sudden we pick up a cancer when it's tiny, when it's less than half the size of a marble. We see a nodule that would not have been picked up on any other thing. And we have this dilemma of what do we do? How do we biopsy that? Because if you can imagine trying to put a needle in that, for one thing, it is moving. You can't stop your patient from breathing. So the thing moves about 2 centimeters, 1 centimeter, 1.5 centimeters in each direction. So every time you breathe, it moves like this. So it becomes almost impossible to biopsy these really small lesions. Well, we don't want to go take you to surgery and take out something that's not cancer. Our goal is not that, although we will err on the side of it possibly being a cancer if we can identify it. But if we can biopsy it and prove that it's not, or biopsy and prove that it is, it changes our whole way of treating you. If we prove it is a cancer, we go after it right then, and then you've got an excellent chance of cure because it's small. Well, this spin technology that we have, that again, none of the other hospitals around us have, allows us to go in a couple of different directions. And this is just a recent case that we did last week. You can see how small that lesion is, that little white dot there. I don't have a pointer, but this little white dot is what we're trying to hit. Well, every time the patient breathes, it moves in and out of the space where we're able to see it. What this allows us to do is gate that to the respiratory rate. We basically get a CT scan in the morning, and then we take the patient to the operating room, and we're able to virtually reproduce their chest cavity and where this is, and put a very tiny needle. And this illustration looks like it's a big needle, but it's actually small. Go back. It allows us to put that, and I did it last week before Thanksgiving. On this lesion, it's deep in the lung. I'm not going to be able to find this thing, no way, no how, to take it out. I don't want to take out the whole lobe or half the lung in order to take it out. And I was able to go in, and I didn't biopsy it. It was really almost too small to biopsy. So I went in and put some fluorescent dye right around the tumor. So you see I'm going off to the side of it. I'm not going right through the middle of it. And I got right down that needle tip right down to the tumor, and I just went poof and put in a little fluorescent dye. Well, then when we get you hooked up to the robot and I'm looking at the robot, I just literally tap my feet on the right kind of buttons, and all of a sudden it goes to an infrared type display, so I'm able to see the fluorescence in the lung, and it just glows. So I'm able to identify this tiny, tiny lesion, go in and wedge it out without doing the big operation that would be the whole lobe. A lot of our patients really won't tolerate a whole lobe. You know, they have COPD, they've been smoking all their life, or have a genetic, reason to have it, and bad emphysema, and they just can't tolerate taking a lobe out. But with this technology, not only are we able to do this all with the robot, where we're impacting the patient's body less, they get out of the hospital quicker, they recover quicker, but we're able to actually go in and get these tiny, tiny lesions that we now are beginning to discover. We never would see these before. We would not even see this on a chest X-ray, but it shows up on a CT scan. So the bottom line is we're encouraging you to go to your friends and all of you that think you might be at risk to have lung cancer because of a family history of lung cancer, someone else close in your family's had it, a lifelong history of what we call secondhand smoke, where your spouse smoked, or you worked in a situation where back before they banned smoking, there was a lot of smoke, or whether you smoked yourself. Get screened. It allows us to find these little bitty things. We can either biopsy them or take them out if it's indicated with this new combination of technology that allows us to identify these things and take out a lot less lung and cure lung cancer, which used to be sort of a thing that everybody thought, well, every now and then we get an opportunity to cure lung cancer. Now we feel like we do it every week, or give a really good opportunity for a cure based on all of this technology. And it is something that I think would impact the mortality from cancer in this community possibly more than anything else we do, if we could just get everybody screened that needs to be screened. Okay, I think we're both available for questions, if anybody has any questions. So we taught you everything you need to know. Yes.
When I first moved here, I always wondered about, which was a few years ago, these controlled burns that they have. I was never around that before. And I wondered, is that really good for your health? Breathing that in?
Well, it's not good for you to stand in the road and it's burning like that. It gets really smoky. I remember one morning after I've been here for probably 15 or 20 years, and the Okefenokee swamp caught fire. And my dog woke me up, and I went outside and I thought the neighbor's house was on fire, and I ran around, and the whole town was under the smoke veil. So when that happened, if you're doing the controlled burns, so look at California right now. California does not do controlled burns. And without controlled burns, we would be California. We would have monster forest fires that would burn our houses down and kill us, and ruin our not just our land, but our life. So the controlled burns are very necessary. I think a lot of people think, and it is true, that one of the primary reasons they do it is for hunting. But it is, without that, those forests would not support any wildlife. They get so dense and so thick very quickly with our scrub oaks and all that. So this land, before we moved here, was burned regularly by nature. Lightning strike would start. There were no highways to stop it. There were no, Smokey the Bear or anything, and they would burn not thousands, but perhaps tens or 20 or hundreds of thousands of acres before it stopped. Because the only natural barrier was rivers. So the controlled burns are a necessary part of our life and our environment. Stay inside as much as you can when that occurs. You look at, as Dr. Pender mentioned, there are loads of cities in the world where the majority of the residents on a daily basis wear masks when they go outside because the pollution is so bad. It's not that bad. The chemicals that are in that smoke are not as bad as that. They're not as bad as the chemicals that we know are in tobacco, but they're not good for you. And so the infrequent exposure to a fire like that is not, I mean, it may make your asthma worse, and I'm not an asthma doctor, but you know what I mean. But it's probably not a big risk as far as lung cancer goes. But if you're like where they're having those burns now, those fires in California, they said it's the equivalent of smoking 11 cigarettes a day living in San Francisco right now, if you're outside, because of the degree of soot, in the air. So yes, it is not great for you. It is a necessity. I, firmly believe that. I've suffered from wheezing and sneezing and burning eyes and all that when it happens, but I also recognize that without that, we would periodically burn Thomasville down. So, as they're unfortunately experiencing in California. Anybody else? Well, good. If y'all didn't get enough to eat, go get some more. Is there anything else?
No, I think
No!
already.
Well, I didn't eat. Thank y'all very much.